Okay, looks like we're at a pretty stable number, so I think we can get started. Welcome to the end of February Biocurator Working Group call. Thanks for sharing the announcement slide, Kazong. So today, Clarissa Klein is going to present to us about the DAPC Data Access Protection and Confidentiality Working Group. And then our next meeting falls on Wednesday, March 12th at 4 p.m. Eastern Time, and we will be getting an overview or an update from Genome Connect, excitingly, ClinGen's patient registry on that meeting. I think those are all the announcements that we have, so I will turn it over to you, Clarissa.
Thanks, Marina. That's exciting. Genome Connect is also relevant to what we'll be discussing. Let me get the slides. All right. Can you all see the slideshow?
It's thinking about it. Okay, now we can see it.
Perfect. All right. Okay, so thank you for having me. For those of you who don't already know me, my name is Clarissa Klein. I'm the program manager for Stanford. And today I'll be speaking to you in kind of my role as coordinator for the Data Access Protection and Confidentiality Working Group, or DAPC for short, since it's a bit of a mouthful. We'll be focusing mainly on our upcoming guidance for data collection and sharing for ClinGen curation, but we will also talk a bit about our other work, both complete and in progress. So, for those of you who are not familiar with DAPC, um, it really is focused on sort of data policy frameworks, acknowledging that ClinGen is kind of a complex and evolving curation ecosystem with a variety of different needs. So it's not really a one size fits all approach in a lot of ways. The working group has a range of experts with expertise in a variety of fields, everywhere from curation to legal to policy development to software and clinical practice as well, patient advocacy. And so I want to thank all of our members who have worked very hard on all of these projects. I know some of you are on this call as well. So thank you for that. And so today we're going to be discussing sort of a brief summary of the work we've completed so far. And we'll go through kind of each of these items in turn. And then we're really going to focus on the guidance that is nearly complete but in development, our guidance on data collection, and our code of conduct, which is in development as well. And so, very briefly, one of the first things we did as kind of DAPC came back together was update the terms of use for the BCI. So if you're a variant curator, you have seen and agreed to this. I won't read through every kind of piece of it, but that was sort of one of the first things we updated. And then we spent a significant amount of time sort of updating how we handle conflicts of interest for ClinGen, as well as kind of combining that with some, attestations around how you use ClinGen data. The real goal of this project was to kind of streamline and make consistent how we record and manage conflicts of interest, and also kind of facilitate a way for people to share, new potential conflicts as they arise, make sure we don't lose those. So everybody here, if you are a curator, you have seen this in the GPM, you filled it out, and thank you for doing so. We also have an attestation that is done sort of at the same time annually to not kind of use information and data from expert panels that is intended to be internal for research outside of ClinGen without permission, and it's confidential. That's linked here as well. And then, one of the things we worked on sort of in advance of a code of conduct a bit more complete is a statement on expectations around data sharing for ClinGen members, right? And the real goal of this was to foster an environment, right, that was productive, to avoid kind of running into issues, make sure people, had kind of these expectations laid out for them, as well as to sort of set up a process for if there are concerns, how to raise them, how to kind of work with DAPC to, resolve those as well, right? So some guidance to follow if there are any issues that happen to arise. These are linked in the slides as well, and we'll be sharing these after the call. So if you're interested in any of these, you can also find them by going to the DAPC working group page on the ClinGen website. And then these are our two major ongoing efforts. The first is kind of the meat of what we'll be talking about, which is guidance on collecting and sharing data for curation purposes for ClinGen. And then the second is the code of conduct, which sort of lays out behavior expectations for all ClinGen members, as well as providing sort of a more complete mechanism if there are concerns around member behavior on how to handle that. Also, for consistency's sake, I do want to note we had expected this to be complete by this call. However, NHGRI has requested time to provide additional input. And so as such, everything we kind of discuss after this point, I just want to be really clear. This is pending further input from HCRI and, ultimately the steering committee. So it should be considered subject to change and not finalized. We will be talking a bit also about the development process and sort of the questions we had in mind and the things we wanted to make sure we were taking into account while we were developing this guidance. Obviously, those will be consistent, so I'll focus on those a little bit more as well, because I also think that is more interesting than going through sort of dry policy for an hour. Um, you see, yes, thank you, Jules, for sharing those links. Also, if you do happen to have questions, please put them in the chat. I see Jules is on the call. Jules is one of our co-chairs, and so she should be able to hopefully answer any you have while this is ongoing, and I will try and leave some time for questions at the end as well. And so the guidance on data collection, this is sort of an overview of what it is. So it goes through the different types of data that you may encounter while you're doing curation work, specifically focusing on case level and unpublished data. It's a little different if something is already published, it's sort of out there. The safety, confidentiality concerns are a little different if it's already been published. And so this is really focusing on that sort of case level unpublished data. At various points in the process that you might be engaging with it. So, if your expert panel is collecting or requesting this data, or if it's offered, right, from an external source and you want to accept it, when it's being shared among expert panel members, whether that is a coordinator, providing data to a curator to do a curation in particular, or it's a curator presenting it to the rest of the expert panel to kind of go through that curation. Entering into interfaces like the VCI and the GCI, as well as submitting to things like, ClinVar, the e-repo, or including it in publication work that your expert panel does. All of these are different kinds of collection and sharing. And as you can kind of guess, there are different concerns at each level, right? Something that is accepted for internal use is, there may be different thoughts about that than, something you are putting in a paper and submitting to a journal, right? So why are we doing this? It is in the name a little bit, right? We're really thinking about sort of protecting data, confidentiality of people for whom this data is, very personal. We also want to make sure that we have sort of consistency as much as possible in approaches while acknowledging that, again, ClinGen is not a monolith. So, there will be different needs across different domains, across different expert panels, both in terms of what types of data they'll need and how they can handle it. And so we wanted to provide some guidance so that whenever possible, curators have something to lean back on. They have an approach that we've kind of gone through, we've thought about, the questions of safety. And then really we want to make sure, again, with that we are being transparent, right? Transparency is key with respect to, a lot of the scientific processes, if not all of them. And so, we want to make sure that the guidance we're giving people is both clear and something that people can access because, if you are sharing data with ClinGen, you're going to have questions about how we handle it. And we want to make sure those are clearly communicated. But, at the end of the day, it also really does come down to safe handling of data. And so some of the key questions we had through the development process, right, of this guidance that we were thinking about as we were going through, obviously the big one is what types of data are people going to be engaging with? What types of data should be shareable at different stages in the process? And again, this is something where different groups will very much need different types of data. Thinking about, for instance, kind of confirming phenotype is going to be very different across different domains, across different diseases. And so, people are going to be thinking about different things. They're going to be handling different formats of data and different types. And so thinking through all of those and talking about, okay, what makes something shareable, collectible, what is a little bit more dangerous, what cautions do we want to maybe think about giving. The second piece is, at different stages, who should be able to access the data, both thinking about, kind of in terms of restriction, right? You don't want data to be shared, broadcasted publicly if it doesn't need to be. But also thinking about ensuring that in the future, people who will need to access this data are able to do so. So for instance, if a coordinator transitions and somebody else comes in, making sure that they have access to that data for that group so that when time comes to recurate, you know where that data is, you can access it, you can go back to it, or if there are questions about it. And then also thinking through, kind of method of collection. what kinds of guidance might we want to provide there? In conjunction with collection is storage. And we'll come back to that sort of towards the end, but that was kind of a really big question and also a big area where we really can't be a monolith. And so, thinking about different places where we might want to be storing data, considering how long we want to store it. And then also there are different considerations for short-term versus long-term storage of this kind of data, right? And we need to be thinking about concerns, important factors for both. So some of the key takeaways from this process that kind of pervade, through the entire guidance as we prepare to kind of set this up for release. The big thing is there really is not a one size fits all approach, right? I really want to hammer that home. Curation needs do vary quite substantially, even between types of data for variant versus gene curation, for instance. And you can't, come up with a policy that is extremely prescriptive and goes through every single piece in detail and prescribes that you have to do it this way every single time, because that obviously doesn't work. So it needs to be flexible. And then you really are balancing different key values that are sometimes in conflict, right? So you want to be transparent with the process as much as possible, but there are other things that are important as well, right? Safety and transparency can sometimes interact. Another thing that's really important is being mindful of the fact that the vast majority of people working on these things and going to be handling this data are going to be volunteers, right? And this is both in terms of we really want to make sure we're respecting people's time with what we're asking them to do with respect to data handling. We also want to make sure that we're not putting sort of, undue barriers to safe data practices in front of volunteers, because that just is a recipe for either people, no longer being interested in volunteering because we're making this process unnecessarily difficult, or taking shortcuts, which we really also don't want to happen as well, right? Accessibility is, something that goes kind of with transparency. We want to make sure that we're not, preventing access to data in ways that, we don't need to be doing. We want to make sure that the data is accessible for future use as needed. But, at the end of the day, we also want to make sure it's handled in a way that preserves confidentiality as much as possible as well, right? And so we've developed what we are referring to throughout this guidance as sort of a minimum necessary approach, which I'll come back to shortly. That just sort of guides how we recommend people handle data, across the board. And our real goal through development was to come up with some guidance that was both useful to curators, right? Provides guidance in areas they may be looking for, something to kind of fall back on, how to handle this, but also that's actually practical and implementable, right? Because if it's not practical and it can't really be done effectively, it's just not going to happen, and you're going to have something that's not useful. So, these are kind of the main sections of this policy. I'm going to broadly go through each one. I'm not going to kind of go into full detail on everything because, again, we may be subject to change, but I'll kind of cover the basics of what's included in each section. There's some general information that guides, the entire sort of data sharing and collection process. So that's kind of sectioned into its own bucket. We also have a couple sections on, data that can be collected and shared, as needed, as well as data that can't or should not be collected or shared. And so we'll kind of cover those in conjunction based on sort of the type of data. And then, really it does come down at the end to thinking about storage, right? And what kinds of recommendations we have on storage, since that goes hand in hand with collection and sharing. So, in kind of the general broadly applicable guidance section, we have a couple different things. We do go over data sharing laws. I'm not going to talk about this on this call, but sort of the broad points on that. Everybody should be familiar with the data sharing laws, both local to them and in the US, because ClinGen is US based. This includes HIPAA. This also includes an awareness of PHI, protected health information, and what are considered PHI identifiers. Then we kind of go over sort of, what the minimum necessary is. I'll cover that in a moment as well. And ages and images have additional considerations, because they are kind of more proximate to PHI. We'll go over that momentarily as well. But first, I will kind of dive into something that will go across the entire guidance, which is how we are defining for the purpose of this document and this guidance what it means to share something internally versus externally, right? What the difference between internal and external sharing is. And so there are different types of data sharing. For the purpose of this document, thinking about internal is really kind of internal to the expert panel in this context. We'll come back to the interface momentarily, but so, one kind of collection is, from the source. That's internal sharing. We're taking it into ClinGen, right? And again, specifically focusing on unpublished data here, right? If you're accepting published data, that's different, and the guidance is, a little bit different with respect to that. Um, and then internal sharing within an expert panel can take a couple different forms, right? It can take the form of a coordinator disseminating data to an expert panel member to be curated on. It can take the form of a curator presenting that data again to the expert panel, but also storing it in a location where it can be accessed by other expert panel members is also kind of sharing that as well. With respect to the interfaces, once it's entered into the interfaces, it has the potential to leave the expert panel. And so this is external sharing with respect to kind of what we're covering here, right? We have administrators for these interfaces. They can, if they need to deal with something, they may be able to see this data. So you can't assume it is going to stay within the expert panel if it's put in an interface. And then, thinking about different forms of submission to resources and publication, right? So we've covered this a little bit. ClinVar, the e-repo, including referencing or including data in journal publications for the expert panel. And the reason we split this like this is there really are kind of two levels of what's needed, right? A expert panel needs the necessary information to apply proper codes or to score evidence correctly. And so you need a higher degree of specificity typically with respect to kind of expert panel scoring activities. Um, Externally, you may not need as much information. It may not need to be as detailed. There may be certain pieces of data that you need to apply codes that you don't need to publish, right? And so there is sort of a split at that point in terms of what is necessary to communicate the validity of, what curation you are doing. And so as such, we want to make sure people keep that in mind when thinking about what the minimum necessary is. And so in, this process and this guidance, we really are defining this as sort of, minimum necessary amount of data is the least amount of data at the lowest risk of identifiability to the patient or patients. This applies both in terms of, what's the minimum necessary to collect, what's the minimum necessary to share, right? And so there are different kind of stages in the process where this is really important to think about. At the very beginning of the kind of the curation process, one of the questions to be asking is, if you're thinking about accepting or asking for unpublished data, it is worth considering, what sufficient, what published data does exist and is it sufficient for the purpose we need this data for, right? Can we look, either have we looked and explored all of our options? Is this truly insufficient? And if it is, then it may make sense to request some. And also, right, thinking about the data itself, how much specificity do we really need? Do we need their exact age? Probably not. Maybe we need age in reference to a particular point. Maybe we need range of ages. Maybe we need to know if it's before or after this date, for instance. But we don't need the actual specifics. So thinking about what degree of specificity is actually required for the work that's being done. And then with respect to kind of riskier forms of data, and we'll talk about images in a minute, if that type of data is under consideration and needed, really thinking through what the benefit of getting that format, that type of data is compared to what the risk of that format or type of data, right? Does the benefit of collecting this for the curation actually outweigh the risks that we will be taking by accepting responsibility for handling that data, safety, for avoiding identifiability risks? And so kind of in conjunction with that, asking, are there ways we might be able to use less identifiable data for a, particular purpose, for instance? Can we get away with something that's, redacted or a different format or something that is a little less risky? And so there are two, as we spoke before, there are a couple things that there are additional considerations for. Ages is one of them. For those familiar with the PHI identifiers, ages over the age of 89 are considered PHI. So, you can't share those. We are kind of recommending in the document the stage that, while it may not be practical to collect ages and ranges or references, we do recommend that you don't externally share those. They don't be entered into interfaces without patient consent to case level data sharing. This is because most of the time, what's important is not the specific age itself, but it is what it's in reference to, right? It may be really important to know if somebody was diagnosed, for instance, younger than 40, right? That may be, kind of an important point. And so that is what's important. And that is what we recommend you kind of focus on when it comes to externally sharing this data. And that's going to vary based on expert panel and what the requirements are and what you need the data for. With respect to images, full facial images and similarly identifiable photographs are considered PHI and should not be collected. We'll come back to images later as well when we talk about what types of data can be shared. Something really important to keep in mind when sharing image data is there are often other visible identifiers if it's a photograph, for instance. It may have a patient name right in the corner. It may have their record number included. It may, identify their practice locations. And so if you are handling images, we do recommend you look at them and pay mind to redacting other potentially identifiable information that you don't need. Um, Several institutions also have additional policies or guidelines on external sharing of images. So if you are sharing images with an expert panel, it's really important to be mindful if the institution you are at does have any kind of additional guidance and abide by that as well. And this is included in the section on, data laws and things like that. But again, we really do also recommend that you abide by your institution's policies and practices with respect to data sharing overall, data security. That's also really important. And so, with respect to sharing data and the unshareable data as well, again, coming back to minimum necessary, reduction of risk where possible, but acknowledging through the process, right, needs very much will vary depending on the expert panel. And any data that is already published has a lower identifiability risk, so we recommend you use that when possible. And so this is sort of a very broad, sweeping summary of what kind of we are recommending people share, or recommending that people can share, when necessary, both internally and externally. And I won't go over every single one of these items in this deck because, some are, a bit drier than others. I'm going to kind of cover the ones with interesting considerations or, with a lot of things to kind of think about. And so we will go through some of those now, but we do have this nice little table that Christy has made originally. And this will be included in the guidance as well. But these are all kind of the areas we will be talking about in the guidance as it's published. And so, we're going to start kind of looking at phenotypic details because this is something there is a huge range of what is needed across the board. These are important to, confirm that, you're curating on the disease or gene of interest, right? And so there are certain things that may be appropriate to collect and share internally and share externally, depending on what the need is, right? Certain congenital physical characteristics may be important. Certain health concerns, certain traits associated with the disease or gene of interest, this all makes sense. Potentially successful treatments or therapy relevant to the specifications of the expert panel. Maybe there is something that, would be relevant information that may also be appropriate to share externally. With respect to laboratory values, this is something that will vary substantially depending on the expert panel, right? A hearing loss expert panel may be interested in looking at different types of tests than, a somatic cancer panel. And so, thinking about, with respect to various different lab results, imaging results, functional testing results, we do recommend that when possible, those are redacted to what's necessary, particularly thinking about images. And then with respect to external sharing, a different degree of specificity may be necessary, right? So, for instance, say there's an expert panel and one of the elements of, potentially diagnosing a condition is that you have a certain lab value higher than 100, right? And you collect the value for the patient and maybe it's 180, right? That may be appropriate to collect and share internally. With respect to external sharing, they don't necessarily need to know that the value is 180. What they need to know maybe is that it was higher than 100. So something like that may be kind of a way of reducing to kind of the minimum necessary. Two other pieces of this, particularly with respect to, phenotypic details and, certain types of test results, images, really thinking about what the sensitivity level of that piece of data is, how identifiable is that piece of data. We'll come back to images again momentarily. But there are certain types of data that are particularly sensitive, right? So a great example of this is mental health history. We do recommend when sharing this type of data, you do so with caution, you do so with respect, and you keep in mind that it is more sensitive in some cases. And so, handling that appropriately. Family history is also something as well that we have, a range of guidance on. Again, this may be necessary or relevant for, curation. And so, we recommend that, in cases where it is necessary, you can share it internally. There are some cases where it may be directly necessary to share family history data externally. And in those cases, we really recommend that you pare that history down to, the absolute minimum of what is needed to prove whatever point you need to prove with it. Um, with respect to relatives, any degree of obfuscation can help, right? And so, one of the things we came down to in discussion was identifying individuals based on whether they were maternal or paternal relatives and the degree of relationship rather than specifying, right? So, for instance, aunts can be alternately described as paternal second degree relative. This is a little bit less identifiable. Internally shareable, information on family history that may be relevant, right? How many relatives who have a phenotype of interest, what their ages are, how old they were when they were diagnosed, if they've been genotyped with a variant of interest in conjunction with the phenotype or condition of interest. Again, thinking about sensitive data here, right? Consanguinity may be directly relevant to curation. There are cases where this is going to be explicitly relevant and very much so. And so this is something that may be necessary to collect data on. It is also something that is extremely sensitive. And so we do recommend heavily that people keep that in mind when they're handling data that involves consanguinity. And also, kind of in line with this and with family history, pedigrees, right? Some groups may be handling pedigrees, some groups may have no need whatsoever to handle pedigrees. There is a huge range in what types of information is provided in a pedigree, right? The specificity of it, the level of detail, and the sensitivity of information in that pedigree can vary substantially. Some may have PHI, some may not have PHI. It is very important to keep in mind when requesting whether or not what you are handling is PHI. With respect to kind of getting information and data from pedigrees, there are a lot of cases where it may be more appropriate rather than requesting the pedigree itself to request pieces of data from that pedigree that are directly relevant to what you're doing. In those cases where that's possible, we recommend you take that approach. The other piece of this is, when working with a pedigree, we really recommend you carefully consider how de-identified it is. Can it be de-identified, to as the greatest extent possible prior to even the kind of the collection internal sharing stage. This is particularly the case if this is being shared in an image format, which is a little harder to redact in some ways. We recommend against any entry of pedigrees into curation interfaces or other forms of external sharing, just given the level of detail in a lot of these. So coming back to patient images, we recommend against use of images whenever possible. We recognize there are situations where it may not only be imperative, but it may be the only option to get certain types of data. And so we didn't want to outright, ban collection of these. But as a kind of a general practice, we do recommend against collecting internal sharing or external sharing of patient images. There are cases where curators are working on a particular condition that requires an image for disease phenotype diagnosis, and cases where that is required in phenotypic evidence or phenotypic summary, a report, even redacted or not redacted, is not sufficient to diagnose or to confirm the presence of a phenotype, right? And these are for cases where there is not other evidence or it does not and cannot suffice. So where image is really the absolute only way to do this. Internal sharing in those cases works, but only for that specific purpose. And so as such, we recommend that if those images are collected for this purpose, they are only shared internally between the coordinator who is, inputting the information and the expert in question who is going to be evaluating the disease phenotype, not sharing with the broader expert panel membership. A couple pieces of this. One is that, again, facial images may be included in that subset. Those are PHI. Because they are PHI, we do require consent for those. So if you are going to need those, you need to get consent. For other less identifiable images, we strongly recommend you get consent whenever and wherever possible. So if you are working on a group, you're creating for a group that expects to require image-based data for this specific purpose, we recommend, you contact Genome Connect as a resource. We'll be hearing more about that next month. To kind of work with patients to get consent for data and really mind, if you are going to be handling this data, that is sensitive when you're thinking about how you're going to be storing data for your expert panel. And so that should be taken into consideration when possible. Another circumstance that data may be relevant to curation is sort of the breadth of genetic testing, right? Some parameters may be important. Were certain genes or alleles included? Were other things detected on the test? Did the test even have the power to collect, information on these genes or alleles? And so this is relevant to internal curation, so to kind of be collected and shared internally. Um, there are cases where it may be, critical to share a piece of data around the breadth of testing to demonstrate that the curation is actually valid, right? That we ruled out so and so. With respect to secondary findings in VUS and other genes, there needs to be sufficient rationale, right? Minimum necessary to collect and share these. With respect to sharing kind of benign data externally, right, BS2 and BS4, we recommend, when possible, limiting to counts of individuals rather than specific data on those, right? So some examples here is, this many individuals were seen and documented with the variant, but without the relevant diagnosis or phenotype, or with an alternative molecular etiology, things like that. And then related kind of to breadth is the year range genetic testing was done. This is because, technology has evolved, things change over time. What's included on panels has also changed. And there are cases where this may be directly relevant. I work in pharmacogenomics. There are a lot of cases where, we weren't testing for particular alleles based on, how we define things, prior to certain dates. And so knowing whether something was done before or after those dates may be directly relevant to kind of the power of the test to pick something up, right? And so this is similar kind of in some ways to ages, right? There may be ranges of times that are appropriate to collect and share for this respect. We do note that there may be some particular cases where sharing the specific year testing was done may be necessary. It may be critical. If it's not, we recommend you sort of stay away from years. And then again, noting that exact dates and dates of testing are considered PHI, so those shouldn't be shared. So now we're going to switch gears to talk about sort of the last big section of this guidance, which is talking about data storage. And so the big sort of guiding question we're thinking about with respect to data storage is what criteria needs to be met of sort of a data set storage method in order to be appropriate for use for ClinGen curation. There's not an easy answer to this question. There's not a one size fits all. And so, because of how storage solutions operate, who has access to them, we'll kind of talk about the different pieces of it. Rather than say you have to use this method, we've provided a couple different options for storage solutions. We are always open to hearing about more. We'll come back to that in a moment as well. With respect to kind of smaller scale questions on data storage, one of those is about, data retention. How long should we be keeping data? At this time, ClinGen has no plans or requirements for retiring or deleting data that's collected and used for curation. We do plan in many ways to use that data later for recuration. And with respect to retention, one thing is thinking about sort of what format data is in when it's being stored, right? So thinking about what is being stored for images, whether that's the image or whether that's a list of pieces of information from that image. Another key factor with talking about data storage is talking about ensuring we have that provenance recorded, right? Where is the data for an expert panel located? This is really important for a couple different reasons, right? We need that data to recurate. Inquiries may come up about, how something was done, and we need to be able to reference the data to answer those in some cases. And preparing for potential changes in personnel, right? If a coordinator retires or, God forbid something happens, we want to make sure we know where the data is stored and someone else is able to access it so the expert panel doesn't lose that data, right? Thinking about storage, this is an area where volunteer time, is really critical to keep in mind, right? Because you want to make sure this is something that is usable for as many people as possible and meets their needs. And so what we boiled this down to was, there are several sort of major qualities that we think are really important for a data storage method to, at the very least consider, at the very most strive for, right? And those are listed here. We'll kind of go through each of them in turn and why they're important for data storage, right? So security kind of goes without saying. It is really important. In order to kind of securely store data, there are some recommendations that are kind of more clear cut across the board. One is to, when possible, avoid storage on individual machines. This is because machines can fail, computers can break, and God forbid, all of your expert panel data is on someone's laptop and the laptop dies, right? So you risk losing all of that. The other reason not to store on individual machines, and this is also covered in a lot of data security trainings, is sometimes there are security breaches. Sometimes people get hacked. Sometimes they leave their computer somewhere it shouldn't be and somebody takes it. So that is both an issue of, loss of data and also a potential confidentiality risk. So don't leave your computer in your car unattended. That goes without saying. And as such, sort of cloud storage web applications, they do have different security considerations, but they can sort of be safer in some of those respects. Password protection, for accounts, also really important to ensure that we can keep data secure, between people who need to access it. And with respect to that, we want to have restrictable access, so not everybody can get into it. With changeable permissions as well, right? Sometimes people are curating and then they leave. We want to make sure that they don't have access to all of that data and all of the new data that's going to be used for the expert panel after, maybe 3 years they've been gone. That's, not securely storing it. You also want to be able to grant permissions to new curators. And so thinking about how permissions are handled is really important. This kind of goes hand in hand with access. There may be different levels of access needed depending on what types of data you're handling, right? There may be data types where it really is only appropriate for the coordinator and whoever is actively using it to be handling that data at any point in time. Ideally, we would have a system that allows coordinators to only share that necessary data with people who need it. A system that lets you limit access, revoke access when needed, and again, add it to new curators. Also a system that makes it, viable to add, edit, access necessary files as you kind of want to add data to that storage solution. So, something that makes it really difficult to store data in it is not going to be an ideal storage resource. And then versioning, this is important if, a data is stored particularly in like one type of document or document format, right? We want to make sure that we can maintain provenance. If we need to go back to an old version, we can see who made changes. We can see when changes were made. And so that helps kind of track and keep data, clean for that respect. Um, and then nearly lastly, one really important piece of this is how easy is it to set up? How easy is this to use? Is it easy to maintain, right? This comes back to valuing time of volunteers, reducing burdens on curators and coordinators alike, and in some cases also reducing burden on submitters, making sure that we are giving them options that value their time appropriately. A major piece of ease of use is also how expensive is it to set up and use, right? So some institutions have access to certain resources, others don't. And in order to set those up, people would have to pay for it, which is part of the reason we can't recommend a one size fits all approach. Some institutions also limit access to certain forms of data storage, right? So there are some hospital systems that don't allow people to use Google accounts professionally, for various different reasons. So, for instance, we can't recommend everybody use Google Drive in that respect. Some institutions do not have access to Box, things like that. Um, also what requirements are there to maintain data in a resource, right? Do you have to continually have somebody, for instance, I think with RedCap, there are certain considerations made for, having somebody maintain the account there. And then lastly, consistency is a difficult one with respect to storage. In an ideal world, we would have one beautiful, perfect solution that works for every single case, but we don't, and we won't. Nothing is going to work for everybody. Everybody has different needs, both in terms of what types of data they're going to need to be storing, who's going to need to access it, how frequently they're going to have to change it, what their institutions require them to use. And so it's not going to happen. But there are kind of smaller scale, efforts we can make to maintain consistency in practices whenever possible. In an ideal world, recognizing that we don't live in a perfect ideal world, we'd have the same, anything under the same grant institution could maintain a consistent approach, ideally the same clinical domain, but again, right, while a clinical domain may be under a grant institution, obviously and by design, experts come from a range of institutions, and so there will be different considerations in mind. So, while we were developing this policy, we wanted to make sure we had that in mind when we were making recommendations, because that comes back to whether or not something is useful, right? If it's not going to work, it's not going to be useful. And so We went through a bunch of different storage options. We spent a lot of time discussing them. What we've included in the guidance are we acknowledge these are not the only options for data storage, and all of them do come with trade-offs. They come with pros, they do all come with cons. We evaluated four options that we kind of have determined have the capacity in many respects to meet the criteria we've sort of set out for, a usable and safe storage option. We've listed them here. If you have, questions additionally on sort of what makes each one, viable, again, you can please reach out. But those are Box, Google, RedCap, and Microsoft SharePoint. A very important note I want to make clear to everybody on this call: Google by itself is not automatically HIPAA compliant. It can be HIPAA compliant. In order to do so, you need what's called a business associate agreement for the institution, or a BAA. So if your expert panel wants to store data in Google, we know this is a popular option for many, and you have data that may need to, consider HIPAA compliance when picking a storage option, and you need help setting up a BAA, or you want information about how to do so, please reach out to us. We can connect you with, sort of ways to get that set up. If there are other storage options your expert panel is using or you are using, and they meet your needs for, safe and secure storage, you think these meet a lot of these criteria, and you think it may be a great option for us to kind of evaluate and potentially include in the guidance, please contact us. We would love to have more options for people. The more options we can provide, the more likely it is that everyone can use something that we're recommending. And so, please contact us there. We would love to look at it and evaluate it. Also, if you are in a situation and you're curating where none of these options meet your criteria because of additional concerns that you would love us to consider and try and help you, kind of work on finding a solution for, again, please reach out. We would love to help in that respect too. And so, with respect to this guidance, sort of the next step is, getting that final feedback and approving any changes. We plan to release this in two formats. The PDF of the full guidance will be on the ClinGen website. It will be under the DAPC page. I believe we'll also be including it under the policy page. We are also developing a Git book format of the guidance, which is going to be a lot more legible. If you use the GCI or the BCI, the new help documentation was done in a similar format, also in Git book. We really hope that this will make it both legible and more usable for curators, because rather than be in one really, really long document, it'll be in different kind of chunks related to specific topics. This will also let us link to it easier from the interfaces, so we can link to a relevant section of the guidance, if there is a data entry section, for a particular topic, making it a lot easier to find if you're looking for it. We also are working on support for a way of recording data provenance and where it's stored with the GPM. Once the guidance is finalized, we'll be working with them to get that set up as well for the coordinator. Switching gears for the last 50 minutes or so, very briefly talking about work on the code of conduct. As kind of previously stated, the goal really is to set out clear expectations for behavior and also facilitate sort of a process to raise concerns and enable recourse for individuals who may not be meeting expectations. Throughout the process, we looked at existing ClinGen policies. We looked at other codes for other organizations that are similar. We drew heavily with attribution on the GA for GH Code of Ethics and Community Conduct. So the link is there if you are interested in reading that as well. Again, to be perfectly clear, the Code of Conduct is also pending final NHGR review. So, what we're going to talk about here is also not finalized and subject to change. So we're not going to go too in depth on what's in it. But, the general sense of the Code of Conduct. It covers participation that is either currently affecting or highly likely to affect ClinGen efforts, both internal and external to ClinGen. And, it includes sort of clear descriptions of the types of behavior expected of ClinGen participants, clearly communicates behavior we don't want to see, right? That's prohibited, and provides details on sort of a reporting process. We are also working on support for anonymous reporting. We acknowledge that there are some situations where people may not want to be named, but they do want to disclose behavior. And so we're setting that up as well to make that possible. So again, that policy also needs to be similarly finalized following NHGRI feedback. The full policy is not super long. It's about 3 pages. We are also providing sort of a shorter summary to make that a little bit easier to kind of parse. And again, we recognize not everybody is going to want to read the full thing. So we will make the summary in sort of a 1 slide visual of what the code consists of. in the GPM. We will be working on adding a required attestation saying you've read the code, you understand the code, you are going to abide by the code of conduct in the GPM. And we are also working on developing a form for, if you have concerns, submitting those. If you have any others at this stage too, one of the options is please, you feel free to email the DAPC group. We have our email on the DAPC working group page. It's dapc@clinicalgenome.org. But the forum is just to make it a little bit easier on people as well. And so we're working on that. And so thank you so much for your time for this. We have a little bit of time if you have questions. I know I went through a lot of different things. If you have questions on, what I talked about specifically today after the call, please feel free to reach out to me directly as well. Or if you want to reach out to DAPC leadership at large, dapc@clinicalgenome.org is there as well. And if I think we have a little bit of time for questions.
Great. Thanks so much,
Yes, I
Clarissa,
do
for
want
this.
to. Oh, thanks. Okay, I just want to address the question that was asked in the chat as well for people who didn't see it with respect to the Google sites. I think we did explore this as well, and then Marina answered, you're right. It is not super possible to restrict how the ClinGen site is sort of set up in a way that would be appropriate for this.
So there's another question in the chat. Are there any plans to use two-factor authentication for the curation site?
So I don't know if Matt is on the call. I
I
think he
am
may.
I am
Oh,
on the
perfect.
call.
Matt, would you like to
I
address
am
that
on the
one?
call. Yes. So we are investigating SSO actually across some of the curation tools, particularly currently with the GTI and the gene tracker. I don't know when that will happen. We're kind of just at the investigation stage of that at the moment. But part of that SSO would be having like two-factor identification. It would be and being able to log in, for instance, using different ways of logging in, like using your ORCID ID or login and things like that. So we are investigating that at the moment.
Thanks, Matt. So then Christina asked, wouldn't you need IRB or the business agreement for,
Yes. So this is about sort of any information covered under HIPAA, even for secure methods. So yes, there are requirements for collecting data to which HIPAA applies. You do need to abide by those. We really do recommend against collection of PHI when at all possible. Part of the reason that we think it's important to have storage solutions that can kind of account for this is, first of all, there will be a very small subset of people who, for whatever reason, may need PHI for something, and those kind of should be handled a little separately, but we want to acknowledge that those exist. And then, second of all, people accidentally collect PHI. It's kind of a fact of existence. We can say don't do it and abide by rules all we want to, but part of this is about building in sort of a second layer of safety for if somebody against better judgment does collect something they shouldn't, we want to make sure that it is at least stored in a secure way until that can be kind of dealt with.
yeah, and I will say, as like a clinical molecular geneticist lab director myself and someone who's worked with many VSEPs, I feel like there are obvious pieces of PHI, like Clarissa talked about, like names, dates of birth,
Mm-hmm.
pictures that clinical labs are very clear, like they will not send that along. Sometimes they won't even send along the second, like PM3 variant to not identify that way. But a lot of the other like phenotype information or segregation information, they often feel is critical. And as she said, that is identifying in many scenarios or like ages, extra phenotype information. So just to have that level of security and this policy, I think it's important.
Yeah, thanks, Marina.
So just to add to that, Marina, I think because this is a lot to remember, and it's a little bit of a shift where we're asking you to really be mindful of these extra specific data points, it might make maybe a good idea for either the senior biocurator coordinator or maybe a volunteer from the biocurator team to look over the variant write-ups. So our explicit
Mm-hmm.
write-ups that we do for every variant that goes into ClinVar, the templates, and just go ahead and try to make those templates as generic as you can to kind of maybe remind everybody, okay, we're going to give age ranges here. we're going to give a range of cutoffs here, or wherever you think you can, um, show that criteria has been met, but not give specifics. If if we all went to our variant curation summaries and kind of went some overall edits, it might be helpful for everybody to remember, to just be mindful of that. So that's just a suggestion if that's helpful.
Yeah, it's a great point. A lot of this information that I listed, people will often collect internally to be able to apply codes, but just like you all said, like they shouldn't be included in evidence summaries. We really just need to include the minimal amount of information to say that we met pieces, not exact ages or a ton of phenotypes that are way beyond like what we would be evaluating for PP4 or something like that. So we actually are working right now on the standardized evidence text summary document. I'll be presenting some of those updates on the variant curation working group call in a week. So we can definitely maybe send it along to you guys and see if you have any further guidance and like any of the general summary part too. We can even just add like a bullet or two of think about this when you're describing cases. Because I know it's just so different the way people write up cases, but like a couple bullet points are a link to this guidance when we republish that standardized text document.
Yeah. And I think
Yeah.
one of those things that we're definitely trying to be aware of is to make sure that this is as easy to access as possible in places that it might be useful or needed, right? So linking to it in sections where people will be submitting things like that, linking to it in different data collection sections of the interfaces.
This is Jenny, and thank you, Clarissa. This was an amazing presentation, so clear and really helpful. I guess I wanted to come back to this issue of PM3 and compound heterozygotes. I work with recessive diseases a lot, and we do get anonymized, unpublished data from different labs. So my question is, it's always hard to get that balance right between transparency and then also protecting confidentiality. So for PM3, where do you then recommend storing the second variant if it's a compound het? Should that only be in your data storage, wherever you're storing your data? It should not go in the VCI at all, or you would not include it in the ClinVar summary. Can you give some more guidance on that?
Christy, do you want to chime in
Yeah.
on this one?
Yeah, that would be fine. So thanks, Jenny, for your question. Yeah, at this point, it might be best just to keep it on your VCEP's storage. In the future, though, Matt was telling us that they would love to have a box of text in the VCI where the VCEP could put information in there that's not available to the public. Right now, anything you put in the VCI in any text box, if it's not going into ClinVar, it's going into the eRepro database. So it's technically public. So right now, we don't want anything that you don't want publicly shared in the VCI going in there at all. If eventually we can get a secure text box where it's just the affiliation can see it, maybe at that point we could have that information that we want to share in the VCEP, but we don't want to share publicly. And that might be a nice place for that. But for right now, it's probably better to be safe than sorry. And of course, this is for information that we receive that's unpublished. Anything that's published is fair game, and you can share whatever specifics you want to. There are no restrictions over published data.
Okay, that's great. Thanks. Yeah, and then I guess if anyone has questions, we can then go ahead and answer them. I mean, one thing I've seen, another lab actually commented on one of our VCEP entries and said, well, they say it's likely pathogenic, but that's based on internal data and we have no way of verifying it because we hadn't provided the second variant or, it wasn't published. And so they didn't, they basically said this is a VUS in our hands. So it's tricky. But just wanted to bring that up.
I think your VCEP probably evaluated that other variant and you've put it into ClinVar. So maybe you could just make a statement, another pathogenic variant evaluated by the VCEP that is in ClinVar. I don't know.
Yeah.
At least that would be my response to the person who made the request for more information.
Yeah. Okay. Thanks so much. Thank you.
I will echo
Yeah, it,
just
it is
because
tricky.
it's tricky. It's a fine line because it's definitely something that's come up when the FDA did an audit of our variants that they want as much data as possible in the evidence summaries. And so we really do have to walk that line of being identifiable versus being clear. So yeah, I agree. If you can, classify the other variant and link to that other variant and say that the variant was classified in ClinVar, there's a publicly available classification, or, people can be given a little bit more information upon contacting you. Um, it's
Mhm.
it's just a hard line to balance there.
Right. And that's another option as well, Marina. I'm glad that you said that. I mean, you could always go back to the submitter to your VSEP and say, hey, we've had someone reach out about this. Is it okay to share the second variant or share the ClinVar ID of the second variant with this individual? And if they say yes, then you can.
And then looking, I see that Jules is addressed. Yeah, so there's a question about sharing images for case reports, specifically with respect to facial photos. And again, right, published data is a little different. There should be guidance on that as well. And Jules has that one covered in the chat. And then since we have Matt on the call, I do just want to say, clarifying, in response to Deb's question about case data in the VCI and submission to eRepo. It is my understanding that Christy's correct. Anything that goes in the VCI, it cannot be guaranteed to be, I mean, it should be considered public. Is that correct, Matt?
It is correct. However,
Yeah.
currently it's kind of a mix of the two. Anything that's written by should be considered that when that classification is published, it could be public, because in future case segregation data may be available. But Deb is
Oh,
right
okay.
that
So it's
currently,
not now though. Currently it's not.
yeah,
So
No, it's
currently
not
it's just
now.
the
yeah,
comment that gets sent
yeah,
over. But
yeah,
Yeah. But
that's
you can't
eventually,
correct. Currently,
assume,
case segregation doesn't. Yeah,
yeah, you
okay.
you
we
you cannot assume it will stay that way forever.
yeah.
Yeah.
And
Yeah,
what
and
we
I
want
will.
to do is any field that is like confidential, we would explicitly put on that field that it is
Mhm.
confidential. It would never get exported.
Plus, it is currently accessible to all members who are in the VCI, whether you're in the
Yes.
affiliation or not. So you could
Yeah.
just be someone from a random lab who creates the variant, and you would be able to see the case data comments from the VSEP on the same variant.
Yes, that's a really important piece of it is, right? There are a
Right.
lot of
But you have to
VSEP
log
users.
into the VCI and they wouldn't like you're able to do you track actions if someone is viewing, like tracking viewing, like you would at least log who's been in that record?
Whether or not
No, we
viewing
only
is
track
being
No.
done,
edits.
Okay. Okay.
but they can still view it. Even tracking or no tracking, they can still view it. So it should not be considered private if it's in the VCI or the GCI.
Right. It's just not publicly accessible without a login to the VCI, basically.
Right. Mhm.
Okay.
Yes. But it's not restricted to ClinGen membership. We have many VCI members who are not ClinGen members who are using it for a variety of reasons. So I know we're out of time, but if you have further questions, please feel free to reach out to me or to DAPC in general. We'd be happy to address them. And thank you so much for having us and for all of your
Yeah.
questions.
Thank you, Clarissa and DAPC chairs. We really appreciated this. We'll talk to everyone in a couple weeks. Bye.
Bye, all.